everyone, for this opportunity to speak today. I am a proud recipient of the Gardner Holt um, um, funding or grant, and it's been really my pleasure to be part of this community to which both Dr. Jayaraman and Dr. Price have been so welcoming, and I'm so excited too that Josephine is going to speak about another one of our collaborations, and so just really inspired by her every day. The topic of this presentation, because you're going to hear about some breast cancer collaborations that we have in Ghana, I thought it would be a wonderful opportunity to speak about our group's creation of an international virtual multidisciplinary tumor board for breast cancer patients in Mongolia. And so I'm going to share this presentation with you guys. We can take questions at the end, obviously, but if there's any pressing questions that you have in the middle of this talk, please feel free to shout those out. I do have one disclosure. I am part of the Surgeon Lymphedema Advisory Board for ImpediMed, which does not influence this work at all. So a little bit of background about Mongolia, situated between both Russia and China. It has a population of about 3.2 million persons, so a large potential disease burden there. Interestingly as well, there is about 50% of the persons, the Mongolian people live rurally, but a little bit over 50% live in the city, in the country's capital, Ulaanbaatar. And additionally, the National Cancer Center of Mongolia, with whom we partnered for this collaboration, is centered in that capital. So both the University of Utah and the University of Minnesota were super excited about this collaboration with the National Cancer Center of Mongolia because of the large number of women who we could impact their care and improve their breast cancer care through this partnership. Additionally, I should say that 85% of all of the breast cancer cases in Mongolia are treated at the National Cancer Center of Mongolia. The breast cancer rate in Mongolia is about 6 to 8 persons per 100,000. This is much lower than in most developing nations, and in part, this is because within the country of Mongolia, similarly to in many low and middle income countries, there is not a screening process for breast cancer. But I think what's really important is that breast cancer is the most diagnosed cancer amongst women in Mongolia. And 90% of the women who are diagnosed with breast cancer in Mongolia are diagnosed at a late stage, either stage 3 or stage 4, which results in a very high mortality rate. So just as in any piece of literature, there's a range. The higher end of the range is 88% mortality rate from breast cancer at 5 years. I've seen it quoted as low as the high 60s, but that is very different than very disparate from the mortality rates that we see in the United States and other high-income countries. So again, when this opportunity arose for both myself and the University of Minnesota, we saw this as something that could really, again, positively impact the lives of many people. So initially, we performed a needs assessment with the National Cancer Center of Mongolia, and our main point person was Batsuk, who is the head of the Breast Cancer Center at the NCCM. And ultimately, one of the things that came up that could be a potential point of impact was that the National Cancer Center of Mongolia did not have a breast cancer multidisciplinary tumor board established at that time. We know historically from a lot of literature, not just in breast cancer care, but also in pancreatic care, cancer care, colorectal cancers, leukemias, lymphomas, that multidisciplinary tumor boards improve patient outcomes and lead to improved patient survival. So this, again, seemed like a good starting point for pursuing those goals, which are all of our goals, right? To improve patient outcomes and survival in other countries. There is, or was, I should say, still is, a paucity of literature around international multidisciplinary tumor boards. So this seemed like a good point of scholarship. And then there was even less literature about performing virtual tumor boards. So in the inception of this multidisciplinary tumor board, we wanted to set ourselves up for an opportunity to also study this quality improvement project. And I'd say educational project as well. So for methods, our multidisciplinary tumor board involved 3 major cancer centers: the National Cancer Center of Mongolia, the University of Utah Cancer Center here in Utah, and also the University of Minnesota. We met with the Mongolian team virtually. It's usually around 6 p.m. to 7 p.m. once a month. The tumor board, our goal was for it to last about 1 hour, but usually it lasted between 1 and 1.5 hours. It was conducted in English, and this is something that the Mongolian team actually preferred. We also were very fortunate to have one of our University of Utah students who did his mission work through the LDS Church in Mongolia, who came to every meeting and is still present at most meetings. He is fluent in Mongolian and was an interpreter for us if needed. And then each Mongolian tumor board, a multidisciplinary tumor board, had participants from surgery, medical oncology, radiation oncology, radiology, and pathology. Additionally, we sometimes had genetic counselors there, physical therapists, psycho-oncologists, lots of different teams, but it was really important to always have someone present from surgery, medical oncology, radiation oncology, radiology, and pathology. And I will say that many a time our radiologists previewed the imaging that was presented at these tumor boards, and sometimes we had pathology, not the slides, but photos of the slides sent to our pathologist here at Huntsman and the University of Utah for review, which is just an exceptional resource. The Mongolian fellows and attendings selected the cases that were presented at the tumor board, and 15 patients were presented during the 12 months that we studied for this project. Consent was obtained verbally by the Mongolian team, and then everything that was presented was de-identified. So this is from photos to slides to PowerPoint presentations given for each tumor board. Only de-identified information was presented. And so that's also the information that we had collected was all de-identified for future documentation and studying this intervention. We created a standardized template for the multidisciplinary tumor board, and I think that was a real learning point for our team early on. In the United States, we have a pretty standardized way of presenting patients at a breast cancer tumor board, starting with basic past medical, surgical history, gynecologic history, and a description of the physical exam. In my training as both a resident and a breast surgical oncology fellow, we often included photographs, which would help us think about a stage, because how a tumor is extruding from the skin or the description of the skin can lead us to think about a different stage than if we omit that information. And then also the cosmetic outcome and different cosmetic considerations when we're thinking about the reconstruction and pulling in plastic surgery or doing an oncoplastic approach or a lumpectomy. Additionally, we want to be really clear on the pathology from the biopsy and the pathology from surgery and all the interventions, including the chemotherapy regimen that is provided to each patient. So having a really standardized format was important in not only the communication, but in the decision-making. We additionally reviewed the imaging and pathology, as I mentioned before, in most cases with our team. And then we also summarized the recommendations. This was another learning point. Sometimes at tumor boards, we can hear a lot of different opinions from a lot of different individuals and just kind of ponder, I wonder what the best approach would be. Not everyone always agrees. But one thing that the Mongolian team asked of us pretty early on is that, okay, we've thrown out all of these recommendations. What's our summarized recommendation? And I think that was also very helpful for communication and transmission of recommendations to hopefully the patients and certainly the other members of the team. So for our results, I've broken this down into a couple of different buckets, you could say, because we learned a lot from this collaboration. Let's start about kind of describing the patient population of the patients that we saw at our discussed at our multidisciplinary tumor board. The median age of the patients was 39 years. 100% of the patients were symptomatic at time of presentation. And this goes back to what I mentioned earlier. None of these patients had screen detected breast cancers. These were all individuals who either presented with breast pain or a breast mass that was then worked up and found to be cancer. And again, this is very, well, some of these things we'll talk about may be more specific to the tumor board that we conducted. This is very indicative of the population of breast cancer patients in Mongolia, because mammography or screening mammography is rarely utilized in the country. 86.7% of the cancers presented at this tumor board were invasive ductal cancers, and 13.3% were metaplastic cancers. And this is really interesting. Metaplastic breast cancers are exceptionally rare. And so one could say, well, were these misdiagnosed? But this was actually after our team reviewed the metaplastic cancers that we were seeing, because it piqued our interest too, the first time that a metaplastic cancer was presented. Metaplastic cancers are really aggressive tumors. They have high mitotic rates, and they're really grossly very ugly. And so what can happen sometimes with these is it's actually an aggressive different type of tumor, but the cells are so well, ugly is probably not the best term, but that's how the pathologists usually describe it, are so difficult to categorize because of the really high mitotic rate. So these were reviewed at our institution, and 13.3% were metaplastic cancers originating in the breast. 53.3% of the breast cancers presented at this tumor board were estrogen positive and progesterone positive. 60% were HER2 positive, and 13.3% were triple negative breast cancers. This is also really interesting. By far, the most common type of breast cancer that we see nationally in the United States and globally in the world are estrogen and progesterone positive breast cancers that are HER2 negative. They're the most common cancer that we see. Now, you could say, well, for this tumor board, the cases that would be the most difficult in treatment and probably the most refractory to treatment would be HER2 positive breast cancers and triple negative breast cancers. And so those were sought after for the presentation, and that might be the case as well. But we did see a higher percentage of more aggressive cancers like the metaplastic breast cancers at this tumor board, as well as more HER2 positive and triple negative breast cancers than we typically see. 40% of the cases presented were stage 2, 60% of the cases presented were stage 3 or stage 4. There were no stage 0 or stage 1 breast cancers presented. Again, a stage 1 breast cancer or stage 2 breast cancer is just easier to treat and probably isn't going to be as likely to be presented at a tumor board. And then 26.7% of all the cases were recurrent breast cancers, refractory or recalcitrant to prior treatments. I will say also, as far as median age goes, that does jive with the literature that we see coming out of Asia. There is an incidence of breast cancer peaking around age 40 to 50, which is about 10 years prior to where we see the peak age incidence of breast cancer cases being diagnosed in the United States. As far as diagnostic patterns for breast cancer, what we saw with the patients that were presented at the tumor board, which is also indicative of the way that breast cancer is worked up at the NCCM, which is the highest volume center in Mongolia. So we can kind of extrapolate that to how cancers are triaged and worked up in Mongolia. It's very different than it is in the United States. So 40% of the patients were evaluated with mammogram. This is very unusual. And actually, it took us a little while to kind of realize that mammogram was being omitted. At first, we thought, well, maybe in the templated slides, the mammogram is just being left out, or maybe those pictures just aren't being really well transmitted, so they were excluded, or that they don't have a good screenshot of the mammogram. But then we learned pretty quickly that at the NCCM, their mammogram machine was actually down for a period of 6 months. So we were seeing all of these women who had had an ultrasound of the breast and who were getting a CT scan of the chest. And initially when we saw that, we thought, again, like, oh, they're doing a CT scan of the chest to check out the nodal involvement and to see if there's any lung mets. But hey, where's the CT of the abdomen and the pelvis and the bone scan? Why is that not being done? And as we investigated a little bit more, we realized that there was no diagnostic mammography currently at that site. So these 40% that were evaluated by mammogram had come from a neighboring hospital that was a private center that had their own functional mammogram. And again, screening mammography never done. CT scans of the chest, you might think, well, you're getting more information than you are from a mammogram, but actually CT scans of the chest are really insufficient for ruling out multifocal or multicentric cancers. So they might pick up one cancer in the breast, but the breast is not being compressed. And a lot of times the breasts kind of fall out of the field of view of a CT scan because the woman is laying on her back. We don't actually recommend CT scan of the chest as like the ideal imaging modality for figuring out, do we need to do a mastectomy or is there a potential to do a lumpectomy? As far as the number of patients who are getting a PET CT or a CT of the chest, abdomen, and pelvis and bone scan, that is something that we always recommend when someone has a recurrent breast cancer. And it's also something that we always recommend if someone comes in with stage 3 or stage 4 breast cancer, because you want to know the extent of disease in part because you're going to follow that to see if there's a change with therapy. In part because you wouldn't do surgery in most cases of metastatic disease, and in part because you might need to employ other therapies such as radiation if someone has brain mets. And so there was an underutilization at the National Cancer Center of Mongolia of staging, systemic staging, which was really important. 100% of the patients who were diagnosed and presented at our tumor board received a core needle biopsy of the breast for diagnosis. This is really important because something that we've moved away from since the 1990s in the United States is doing an excisional biopsy for diagnosis because it puts the patient through a surgery when we can just take a little piece of the tumor with a needle, much less invasive. And that is already being done at the National Cancer Center of Mongolia, which was awesome to hear. But the axilla and spread of disease to the axilla was never being tested via core needle biopsy. And so this was another point where we thought, hey, maybe we can intervene in this way and result in decreased escalation of axillary surgery, which is important for de-escalating the risk of lymphedema in patients who survive. As far as treatment patterns for these patients at the National Cancer Center of Mongolia and at the tumor board, we learned a lot about the common practices within the country of Mongolia. So 66.7%, or about 2/3 of patients, received neoadjuvant chemotherapy if they were appropriate for neoadjuvant chemotherapy. So these are for like really aggressive tumors like HER2-positive cancers, triple-negative breast cancers, advanced disease. This was, again, another area where we could improve or at least help and shift kind of the thought process in the treatment of breast cancer patients in the country. Neoadjuvant chemotherapy really should be prioritized if a patient is not going to be resectable without shrinking the tumor first with chemotherapy, and is probably systemic therapy is probably the most important piece of the treatment for survival in patients who have HER2 positive or triple negative breast cancers, because those treatments, the chemotherapy, is going everywhere in the body, and you would expect the cancer to shrink in the breast, as well as any cancer cells being killed that could be traveling through the bloodstream. 55% of patients received Herceptin, and this is 55% of the HER2 positive patients. This was another area where he said everyone who is HER2 positive, if at all possible, should receive Herceptin. And Herceptin nationally has become much more cost effective. This isn't something that ended up being cost prohibitive when we talked to our colleagues in Mongolia. They just simply weren't always giving this medication. Herceptin is something that we kind of think of as like the miracle drug, because after coming on the market, especially Herceptin and Perjeta, we saw much better survival rates in women with HER2 positive breast cancers. So we wanted to make sure to stress the importance of its use. A modified radical mastectomy, where the breast and level 1 and level 2 axillary lymph nodes are removed, is the most common procedure performed at the NCCM. And this is right in line with the diseases that we were seeing at this tumor board. It did let us know that sentinel lymph node biopsy was being very, very rarely performed. In fact, it wasn't performed in any of our patients presented at this tumor board. But again, when you have patients presenting with really late stage disease, it might not be appropriate. As we mentioned earlier, there was a lower number of estrogen and progesterone positive breast cancer cases presented. And of those, not that many, only about 60% of those patients received hormone blockers. And this is not uncommon in the world of breast cancer, but always something that here in the United States, as well as in Mongolia, that we wanted to promote. Hormone blockers or endocrine therapy, such as tamoxifen and letrozole, are inexpensive and very well tolerated by most patients. The most common side effects we see from women are arthralgias and menopausal side effects, which makes quality of life not something that many women well, it does impact quality of life, but it's much better tolerated than chemotherapy that causes your hair to fall out, nausea and vomiting, and weakens your immune system temporarily. So again, an area which we wanted to spend some of our time and focus on educating our Mongolian colleagues about the importance of improved survival and decreased rates of recurrence with compliance to endocrine therapy. 6.7% of these patients received radiation. Very low numbers of patients receiving radiation, especially when you consider the extent of disease of the patients that were presented. Pretty much all or most should be getting radiation. And then autologous reconstruction was offered to some of the patients who had stage 4 disease, which was something that we also wanted to work to change. For all the patients that were presented and for all of the recommendations that were given at this tumor board, one of the final things that we did or analyzed was to say, like, what kind of buckets were these, did these questions and recommendations fall into? And as you can see from the first graph, the most common type of question that was posed was about treatment. Other common question types were regarding palliative care, also appropriate, or diagnosis. Do you think this is stage 3 or stage 4? Is this a metaplastic cancer or a squamous cell cancer? But by and large, 75% of questions came down to treatment. We didn't further subclassify this, but it's important to note that the majority of these were chemotherapeutic sequencing questions, but some of them were also for radiation and should we do more surgery. And then as far as recommendations go, there were recommendations about systemic therapy. Again, 40% of the recommendations, surgical management, another large topic, changes in pathology and changes in imaging, or recommendations around pathology and imaging. I will say that there are certainly limitations to any paper that is published or any question that is posed within medicine, and our study is no exception. We had a small sample size, 15 patients over 12 months, makes it difficult to draw definitive conclusions about anything, but our real goal with this paper and this work was to host a tumor board, which we found was feasible to do that virtually, and B, to kind of characterize this tumor board for other institutions. We had a short follow-up period. Since it was only conducted over a 12-month period, most breast cancer survival and recurrence rates, big things that we want to know about, those are going to take years and years to follow up. And I would say any follow-up of these patients was very difficult for us to obtain. We asked the Mongolian fellows who presented the patients multiple times to provide follow-up of these patients, but when they lack an electronic medical record at the NCCM, and surgical fellows are pulled in a million directions all the time, it was very difficult to get that information. We received follow-up reports 0% of the time. It's something that we are looking into for the future. So, in conclusion, we found with this project that virtual multidisciplinary tumor boards are feasible. I would also say that these are very cost-effective. Dr. Jayaraman mentioned that I have a young child, and I will say, this opportunity to be part of the collaboration with Mongolia came at a time where I had just delivered, and at a time where our world was still trying to navigate COVID. And I think that all of the things that we sometimes see as like, oh my gosh, this is going to impede my ability to do work in a country that is far away, ended up being a way for us, both at the University of Utah and the University of Minnesota and the NCCM, to think outside the box and to create something really meaningful, despite these limitations, quote unquote, that we may see or imagine because of a COVID world or something like that. The NCCM breast cancer patients that we learned more about through this virtual tumor board are young. They present at a late stage, and they have very aggressive cancer subtypes. Is this true for all patients in Mongolia? As I kind of alluded to earlier, I don't think that we can make that assumption right now. Tumor boards are notorious for presenting some of the most recalcitrant and difficult cases. But as I mentioned, some of the literature does suggest that women in Asian countries are presenting at a younger age. We have seen come out of some of the literature in sub-Saharan Africa that the distribution of various cancer subtypes is not always similar to what it is in the United States. So in Ghana, for example, there's a higher percentage of triple-negative breast cancers than that which we see in the United States. So we could have some important findings in the future that we learn about Mongolia as well. And then the presentation at a late stage was not a surprise. It's one of the reasons why we wanted to do this important work. Another conclusion from the paper is that the role of performing a diagnostic mammogram and staging prior to surgery is something that's really important for most of the patients in Mongolia. Because they're presenting at a later stage, we want to make sure that they're not metastatic before taking them to surgery. And performing a diagnostic mammogram is our best way of making sure that we're also not missing something in the other breast or somewhere else in the breast where we could maybe avoid a mastectomy and do a lumpectomy. Improved administration of systemic therapy first. So that's chemotherapy prior to undergoing surgery is really important. Specifically, prioritization of neoadjuvant chemotherapy, HER2-directed therapy, specifically Herceptin and Perjeta, will not only shrink the tumor, but will also improve patient outcomes in both long-term survival from the disease process. We would not have been able to do any of this work without the help of many amazing collaborators. A huge thanks to the Center of Global Surgery, not only for allowing me to present this work today, but for allowing me to do this work, to Ray, to Sudha, Dr. Jayaraman, and also Angel. He was one of our former global surgery fellows who helps me with the data collection and the tumor board prior to starting residency in general surgery this last year. A big thanks to many collaborators at Huntsman Cancer Institute, but specifically to all-star pathologists, Dr. Malo and Dr. Golbachi, who tirelessly reviewed many photograph slides and gave their inputs. And then a huge thanks to the University of Minnesota, specifically Dr. Tuttle, who was one of the breast cancer specialists and surgeons there.